Dr. Kaul, sir, with your permission, shall I start the event?
Please do.
Thank you, sir.
You don't need permission also. You can do it without permission. Because the risk in asking for permission is that sometimes it's not given.
But this is our protocol, sir. As an internal protocol, we always
sir, we are live now.
Post director is aware about.
Okay, sir. Okay, sir.
Thank you. Right. So good evening all. I am Dr. Sanket Nevale, representing Medical Affairs at Emcure Pharmaceuticals, and I welcome once again to everyone to No Thrombosis Workshop in Acute Ischemic Stroke. Today, from Emcure end, we have Dr. Onkar Swami, sir, who is the Director of Medical Affairs, and we have Mr. Prashant Agarwal, who is the General Manager Business and representing his division, Tenectase. I'll now take the pride in introducing our course director, Dr. Subhash Kaul, sir. Sir is a senior consultant and stroke specialist at KIMS Secunderabad and chairman of KIMS Foundation and Research Center. Faculty for 27 years at Nizam's Institute of Medical Sciences, Hyderabad. Former professor and head, Department of Neurology and Dean at NIMS. 120 publications in national and international journals. He was a principal as well as the co-investigator of several national and international projects, including largest single center, Hyderabad Stroke Registry, which was funded by ICMR. He's a state teacher award by Telangana government in 2017, past president AP, Neuroscientist Association, past president Indian Stroke Association, and past president Indian Academy of Neurology. Sir, we welcome you for the event. We have Dr. S. Meenakshi Sundaram. Sir would be the moderator for today's program. Sir is a senior consultant neurologist at Apollo Hospitals, Madurai. Over 20 years of experience in neurology, presented papers at various prestigious national and international forums, recipient of the Best Research Paper Award at the 10th Annual Conference of Indian Academy of Neurology, Lucknow, 2002. Principal investigator for many international trials, such as refractory partial epilepsy, stroke, acute stroke intervention trial, and PD trial. Editor of the South Asian edition of the book Practical Neurology by Jose Pilla, Walters Kluwer, December 2020, and also contributed to many books on neurology. So we welcome you for the event. We have our second moderator, Sir Dr. Anand Devanza, who is lecturer in neurology at Medical College, Nasik, also a consultant neurologist at Narayane Hospital, and also have a private practice in Nasik. He has 13 different set of qualifications from India and abroad, multiple presentations in national and international conferences, publications on stroke, epilepsy, etc. He is a member of IAN, AAN, ACP, ENS, MDS, and IAP. The special field of interest is epilepsy, electrophysiology, and headache. So we welcome you for the event. Our first speaker today would be Dr. Satyan Nandasar, who would be presenting us on the topic thrombolysis in high-risk patients. He is a consultant, Department of Neurology at B.L. Kapoor Super Speciality Hospital in New Delhi, and sir has more than 10 publications in his journal of international repute. We welcome you for the event, sir. And lastly, we have Dr. Dhananjay Dubergerser, who is our second speaker, who would be talking or presenting the case on It's Not a Story Until Something Goes Wrong. Very interesting topic. And to take you a brief about him, he is a consultant neurologist at Chaitanya Neurocare, Nasik, multiple publications, poster presentations at conferences, and practicing since 2010. Sir, we welcome you for the event. With this, sir, I would like to hand over the session to our course director, Dr. Kaul, sir, for context setting. Over to you, sir.
Okay, thank you very much, sir. Dr. Sanket. I think there must be some people who are new for the first time, they must be joining this program, and there are some who must have joined it before. But I can tell all of you that this is a very unique program. In fact, when it started, I myself was not sure of its power and its impact which it would have on our learning, and its regularity with which we are meeting month after month. And the main highlight of this point is that it gives the opportunity to an individual practicing doctor who is treating patients day in and day out and facing all the challenges and then sharing them here. This is not possible in big conferences where there is so much of rush for crowd and not very much time, not so much of opportunity to discuss and interact on one-to-one basis. So this is amazing opportunity. I have myself learned so much from all my younger colleagues, from my contemporaries. And because, as we all of us know, that guidelines and clinical trials are always done in controlled environment. But patients don't come from controlled environment. They come from totally uncontrolled environment. And they don't know that they have to have the patient of stroke doesn't know that he's not supposed to have a past history of brain hemorrhage. He has it. It's a free for all. And then he comes to a doctor, and the doctor has to then decide what to take. And the other limitation of clinical trials is that the guidelines, I would say, when the guidelines are published, they go by statistics. 60% did well, 40% did not do well. Therefore, this is the correct drug. So it ignores the 40% who did well. It ignores those. It just goes by statistics. Whereas clinical medicine or clinical practice is always, the way we see it, it is individual. It's case by case. Patient comes to us case by case. They don't come as composite of 10,000 patients or composite of 20,000 patients. So therefore, we have to learn it that way. And this is a very good opportunity. And I'm sure today also, I was already seeing there are very, very interesting cases and interesting discussion. And it's always a pleasure for me to have moderators like Meenakshi Sundaram, who is a live wire, who is himself a mountain of knowledge. And we are going to hear from him. And today I'm also meeting my old friend. I can't see him now here. Dr. Anand, are you around? Yeah. So over to our first speaker of tonight.
Sure, sir. I would like to invite Dr. Satyan Nandasar, who will be presenting on the topic on his case, thrombolysis in high-risk patients. So I have presented the slide on your behalf, sir.
Thank you. Thanks a lot, Dr. Sanket. So I'll be going directly to my case. Actually, I'll be talking about a case which I perceived was a difficult thrombolysis for me. And this patient was thrombolized a good 1 year back. Still, I wanted to share the experience. So here, can we move on to the next slide? Yeah. So she's a 65-year-old female who's a known case of hypertension, hypothyroidism, dilated cardiomyopathy with a low ejection fraction of only 15%. She also had the comorbidity of chronic kidney disease and ulcerative colitis. She had presented to a hospital with the chief complaints of acute onset left-sided weakness with slurring of speech, which was noted since 2 p.m. She had reached our hospital at 3:30 p.m., that is around 90 minutes after the onset of ictus. And among the medicines she was already taking, which was perceived to be important from my side, was that she was on icosapent 75 mg, atorvastatin 20 mg, Theranorm 125 micrograms, azathioprine 100 mg per day, and mesocol 800 mg per day. The last two medicines being given for her ulcerative colitis. Next, please. So on examination, a rapid examination was done, suspecting an acute stroke, and she was found to have normal vitals. There was dysarthria, gross dysarthria. There was subtle right-sided facial weakness, which was not so very, very glaring or very prominent. It was plus minus type of right-sided facial weakness, and the power was definitely weak. And her left upper limb was 3/5, and left lower limb was even weaker at 2/5. Next, please. So we have suspected that it is an acute ischemic stroke. Per se, because right side facial was plus minus, we did give it a thought that it could be a brainstem stroke, or if the facial palsy was subtle and it was minimal, we could neglect it, and it was suspected it could be a right MCA stroke also. So we ordered an emergent NCCT head to be done, and the MCA territories were looking fairly well represented, with no obvious hypodensity which could be made out on the plain CT image. Next, please. So we had contemplated that as she is in the window period and with a disabling stroke with a NHS of more than with an NHS of around 5, but a disabling stroke, we had made up a mind that we would be going for IV thrombolysis of this patient, irrespective of the location of the clot, or irrespective of the nature of the vessels before doing the thrombolysis. So we while we were shifting her back from CT suite for initiating IV thrombolysis, the patient had 2 episodes of vomiting. She became drowsy and fell off the stretcher, bumping her head onto the floor. She was wheeled back to the emergency room. Vitals were assessed and sensorium was reassessed. Now she had become drowsy. But she was arousable and she was responding to verbal commands, though intermittently. And the power of left upper and lower limb had also reduced to 2/5. Initially, only the lower limb was graded at 2/5. Now even the upper limb was at 2/5. Next, please. So next slide, please. So after re-evaluation, I think you've skipped one slide. You need to go back one more slide.
So this is the next slide after this.
Okay, yeah, sure. Okay, thank you. So initially, because there was a history of recent head trauma and she had become drowsy, it was imperative as a clinician on my mind to rule out any hemorrhage which might have happened, or any such thing which could have been a major contraindication for thrombolysis. Thus, I was not very comfortable in initiating a thrombolysis in a patient who had just sustained a major head injury. Being a fall from a stretcher from a good height of 2 to 3 feet was deemed as a significant occurrence from my side, and thus she was shifted back to the imaging room. This time, the option was there for me whether I could do a CT scan or just to rule out a brain hematoma, which could have been or a traumatic contusion, which might have been picked up on the CT, or I could have got a MRI brain done. The reason I chose MRI brain was because earlier also, because of this subtle right side facial weakness which was pricking my mind, I thought it could be a brainstem pathology also. So why not to get an MRI brain? The few sequences which I needed, DWI, FLAIR, and SWI. So an MRI brain was done, and initially our residents were there, and it was initially reported that the DWI is only showing the right hyperipal DWI hyperintensity, which was not at all seeming plausible to me. So I asked the ADC images to be sent, and this is what the ADC maps showed. Next slide. So the ADC did show midbrain, the right side of the pons was low on ADC maps, and this was quite collaborating with the weakness of the left upper limb, lower limb, and the subtle right side facial weakness, which was plus minus, to be honest with. But this was being explained by that, and thus I went back to the console and rechecked the DWI films. Can you go to the next slide, please? There was an evolving infarct. As we can see, there were the intensity of the two sides of the pons was not at all symmetrical. There was an evolving infarct in the right side of the pons, which was probably missed by the residents, and this was deemed to be the exact cause of the patient becoming hemiplegic on the left side, and probably also lapsing into drowsy state because of the involvement of the brainstem structures. Next slide. flare was only showing hyperintensity corresponding to the right parietal lobe infarct, and the otherwise the flare images were negative for the midbrain infarct, and there were also there was no other obvious hyperintensity which was to be noted on the flare images. Next, please. SWA images were also reviewed just to look at the possibility of any hematoma which might have occurred or any contusions. There was no evidence of any contusions on the MRI or any evidence of major IC bleed or subdural hematoma or even a small subarachnoid hemorrhage, which may have been a contraindication to IV thrombolysis. The only thing which made me go suspect the presence of any IC bleed or any subdural bleed was the presence of the patient becoming suddenly drowsy after the fall. That was what alerted me that I should be alert to that possibility. There could be a bleed also, and that is why I opted for this whole exercise of getting the repeat imaging. So while we were at it, I thought before thrombolysis, it would be I would just go and get the angio also done. So the TOF MRI brain, TOF angio was done of no, please move to that. Yeah. And that showed that the basilar was occluded, hardly proximal 0.5 centimeter of the basilar was seen, and the left vertebral artery was also very poorly formed or poorly visualized. Although it's a TOF image, so not be overreading, but definitely there was a cutoff at the proximal basilar artery itself. So this did entail that a large portion of her brainstem was at risk for further ischemia, and she may have cardio or respiratory depression also, and might have had a further worsening, and even the cerebellar territory could be at risk for infarction. So then finally, next slide, please. Next slide. Yeah. So the question finally was towards resolution that whether I should be initiating IV thrombolysis or no. The main contraindications which were going through my mind was a recent fall 30 minutes before. You can go back. Ulcerative colitis and chronic kidney disease, although it has been discussed at multiple forums, still people, even clinicians like me, are a bit apprehensive in using the full dose of thrombolytic agent for chronic kidney disease. And was the flare positivity in one of the DWA positive lesions a reason for considering for withholding IV thrombolysis? So next slide, please. So as we can see from this AHA-ASA guideline, if there's a severe head trauma within 3 months, then only IV alteplase is contraindicated, and it should be a severe head trauma which should either lead on to a bleeding complication in the brain or to a traumatic contusion in the brain. As a patient as a patient had none of these, which were excluded by the most recent imaging. So this was not a contraindication, and we could go ahead with the thrombolysis from at least this point of view. Next slide, please. With regards to, as I told you, SWA was done and it showed no evidence of IC/EC bleed. Next slide, please. So ulcerative colitis, whether that is a contraindication or no, it is not routinely that we as neurologists see patients of ulcerative colitis having an ischemic stroke. She had been on maintenance with azathioprine and mesocol, and there had been no active GI bleed for more than 5 years. So as we know, the only contraindication to IV thrombolysis is either a structural GI malignancy or recent bleeding event within 21 days of the stroke onset, which is considered to be higher risk from at least GI point of view. So this was not a contraindication at all, and we could go ahead with the IV thrombolysis in this patient. Next slide, please. What about CKD? As AHA-ASA guideline itself says, end-stage renal disease patients who are on hemodialysis and have a normal APTT, IV alteplase is recommended, and however, those with elevated APTT may have elevated risk for hemorrhagic complications. Thus, there was a trial in which lower dose of alteplase was being used, that is instead of 0.9 mg per kg, they'd use 0.6 mg per kg. Similar thing could be contemplated for tenectase also. Rather than 0.25 mg, we could have used 0.2 mg. But because this patient was not on hemodialysis and she had no obvious hemorrhagic complications which had been described, IV thrombolysis was considered for this patient. Next slide, please. With regards to flare positivity, I think I discussed it in last of my presentation also. The patient being a known case of dilated cardiomyopathy with low ejection fraction, the presumed etiology was cardioembolic, which resulted in a shower of emboli. And in this respect, the flare positive lesion in right parietal lobe was a silent lesion, and the acute symptomatic lesion was the one involving the right side of pons, and thus IV thrombolysis was contemplated and rather forced for. Next, please. So now the question comes, as such as a major vessel occlusion, basilar artery has been occluded. Should we stick to either IVT or purely mechanical thrombectomy, or should we go for bridging thrombolysis and go for IVT or mechanical thrombectomy? So of late, there have been multiple studies and multiple neuroradiologists and some of our neurologists who have also turned into intervention. They are also of the opinion that if the intervention can be done at that time itself in the hospital, IV thrombolysis should be avoided. That is what their personal opinion is. But if we are to go by trials per se, at present, we have evidence that bridging is the best. Why I say that is because of this study from which was published in the esteemed journal NEGM, in which again they had compared endovascular thrombectomy with or without intravenous altiplase in acute stroke. In this, 323 nearly similar patients were assigned to either thrombectomy alone and or endovascular thrombectomy preceded by IV thrombolysis. They noted that endovascular thrombectomy alone was non-inferior to combined bridging thrombolysis with regard to the primary outcome. But it was associated with lower percentages of patients with successful reperfusion before thrombectomy. For example, the reperfusion before thrombectomy was 7% in the bridging thrombolysis group, and it was only 2.4% in the non-bridging group. And there was an overall also successful reperfusion, although the odds might not be great, but if you have to go by percentages, even a 5% difference does argue well for contemplating bridging thrombolysis. For example, successful reperfusion was 84.5% in the bridging group, whereas it was 80% in the mechanical thrombectomy group. We might be contemplated to think that there's a risk of hemorrhage does increase. And for that, I'll go to the next slides. Next slide, please. So this is another article which was published in the journal Stroke, in which another meta-analysis was done with regards to bridging thrombolysis achieving better outcomes in direct thrombectomy after large vessel occlusion. And next, please. In this article also, the patients in the direct MT group were compared with the bridging thrombolysis group, and they showed better functional independence. Let us say attained the MRS score of 0 to 2 at 90 days. The odds ratio of the odds ratio of bridging thrombolysis group attaining that were 1.43 as compared to mechanical thrombectomy alone. And they also had a lower mortality at 90 days. The odds ratio were 0.67. And they also achieved higher successful recanalization. And the rate of the odds ratio of that was also 1.23. With regards to symptomatic ICH, there was no significant difference between the occurrence of symptomatic ICH between the two groups, the odds ratio of being 1.01. So with the evidence we have at present, although the studies are looking at, they still continue to look at the possibility of direct mechanical thrombectomy over and above bridging thrombolysis. But in my knowledge, to the best of my knowledge, right now, the best evidence we have is for bridging thrombolysis. We should be attempting bridging thrombolysis before we should be attempting bridging thrombolysis in patients who have a large vessel occlusion, provided they are eligible for same. As of now, I do concur with this evidence at least. Next, please. So now coming back to our patient, the patient was thrombolized with tenectase. I use a full dose 0.25 mg per kg body weight. With being in a private setup, the cost is always a big issue, and the patient was non-affording for mechanical thrombectomy. And in spite of whatever we tried, there was no way we could offer mechanical thrombectomy. Although I was quite pro that, and really was I did want that this patient should undergo mechanical thrombectomy, because the basilar occlusion was tricking at the back mind that she might go into cardiac or respiratory arrest, and medulla could be involved, or those were the things which were going in my mind. So echo again showed the same findings: global LV hypokinesia, dilated LA, and low ejection fraction. MR angiogram, as I showed, had a filling defect in the basilar artery, and rest of the major vessels were normal. And Holter showed multiple runs of atrial fibrillation. Next slide, please. So post thrombolysis, the infarction did involve the opposite side of the pons also. It involved both the sides of the pons. And luckily, cerebellum was spared, and the medulla oblongata and the midbrain structures were also preserved, as well as the PCA territory. Next, please. The only aspect which came in the right superior cerebellar hemisphere, which was concordant with the mid to distal basilar artery involvement at the MR angio. Next, please. The flare positivity was also in the same region. Next, please. The angiogram was also repeated after thrombolysis, and as we can see, the vessels had opened up, and the PCA was very well formed, was very well visualized, the descending portion also, and the basilar. Although the basilar was still not very fully, was not fully patent, but there was but at least the flow was re-established. Next, please. So the patient had a good clinical outcome and improved by the time of discharge. Excuse me. She was discharged on Apixaban 5 mg twice a day. This was done because she had still residual post-stroke dysphagia. And by the time she came on next follow-up, even that had resolved after 3 weeks, and she was shifted back to, because of the renal parameters also, the dosage was kept at same, Apixaban 5 mg twice a day. And by the time of last follow-up, she had MR score of 2 and NIHS of 1. Could you go to the patient video, please?
उठाइए अपने हाथ बस.
So
1 2 3 4 5 6 7 8 9 10. नीचे कर लीजिए धीरे धीरे. अभी वाला पैर उठाइए. 1 2 3 4 5 6 7 8 9 10. नीचे कर लीजिए. अब दूसरा पाँव उठाइए. 1 2 3 4 5 6 7 8 9 10.
could you go to the next slide? She had ataxia as evidenced by this video in both the lower limbs. Next one. I think you played that. Yeah.
आपका नाम क्या है?
सुरेंद्र कौर.
आप कहाँ रहते हैं?
इंदरपुरी में.
क्या हुआ था आपको?
पता नहीं, बैठी हुई थी सोफे पर, घर में चक्कर आ रहा था मेरे को.
अच्छा, फिर आपको कुछ याद है क्या हुआ था आपको?
फिर मेरे को ले आए हॉस्पिटल.
अपनी आंखें कस के बंद करेंगे? कस के बंद करिए. दांत दिखाइए. मुंह में हवा भरिए. कोशिश करिए. कोशिश करिए.
So she had only residual ataxia, and I think we can stop that video. The pre-thrombolysis video was not available because of the rush, and this is what I say to my patients also, that they have to go through what you go through. So that is what I had for my presentation today, and I'll be most welcome for discussion in this one. Thank you. Thank you.
Dr. Kaul, sir.
Yeah, no, I think it's a very, very good case, and a lot of learning in this patient. And I think Satyan has really analyzed it very nicely. And definitely the contraindications we used to think few years ago, those all have been relaxed now. Ulcerative colitis, particularly if it's not actively bleeding, it's not a contraindication. And CKD definitely is not a contraindication. And about the flare, there's one thing. I mean, it's good that you thrombolized, but there is one problem in that flare, that some people might have been little scared to thrombolize because of that flare phenomena. Because flare means that one of the infarcts has happened before 4 hours, which you yourself said. And the pontine one is the recent one, and the parietal one is probably come in a time zone which is earlier. So some people would say that so that amounts to an infarct only, even if it's asymptomatic, but it amounts to an infarct, and some people may be scared to do it. But I think it's a very soft contraindication. It's not there's still discussion going on that. But that could, actually I was thinking that was the only thing which would, and it's right that you didn't think about it, and it's right that you ignored that thing, otherwise this patient would have died from the basilar occlusion. And that's exactly what I'm saying, how we learn from these cases. Particularly this flare thing, when we see, we should not put so much of importance to this flare. After all, when we do mechanical thrombectomy also, at 18 hours, 20 hours, they're all flare positive at that time. So it's not that all flare positive kill the patient or they bleed it. I think the whole concept of flare is that it just tells you the timing. But other than that, so even if it was an old infarct, but it was so small that you wouldn't expect it to bleed. So I really appreciate of your judgment at that time, that you didn't, even though you thought that it was old infarct, but it was too small, it didn't let you come in the way of your decision. Now, the other interesting thing which can be discussed with the patient is that, today we are at a very good situation about this bridging versus mechanical. This recent study which you quoted, what they found is that bridging is better than mechanical. But mechanical alone is also not that bad. So you can now choose your case. Either ways you are right. If everything is correct, then go ahead for bridging. And one of the biggest advantage of bridging is what happened in your patient. There's a good chance, particularly if you are in Tenectase, the vessels may get recanalized, and you may spare the patient mechanical thrombectomy. That is the advantage of doing bridging. At least 30-40% of patients you will not even know, even need. And you don't have to wait. You do the bridging, you do the IV, and after that take patient for mechanical. But in 30% of cases, you will be pleasantly surprised that you don't need it. It doesn't matter. You come out of the angio suite. So that to that extent, bridging is good. But there are some situations where you are afraid of giving IV thrombolysis. For instance, if the patient is having some little bit of bleeding tendency for anywhere, or patient has a recent or couple of years ago history of any brain hemorrhage, or where you don't want to give IV, you want to do mechanical. So there the mechanical alone can be given with a reasonably good outcome. So all in all, I think you have revised all our concepts, and you have taken the lead and gone ahead and achieved an excellent outcome. Fantastic case. Thank you, Satyan. Meenakshi.
So thank you very much, sir. Thanks for the nice comments, sir. And lovely case, really. So I think you have got it right, and everything has gone well. And I should also tell you that, you are very lucky. I'll tell you why. Because when you have a basilar occlusion, I'm sure it was the basilar occlusion, we look at whether it is a proximal or middle or the distal basilar, right? Yours was a distal basilar, sir?
Mid to distal, yeah. Actually, I wrongly told it as proximal. It was mid to distal basilar, yeah.
Much
the
distal.
proximal half a centimeter was well visualized.
Usually, when you have an embolus on the heart, usually it lodges in the distal basilar. And these are the patients who will give maximum trouble. You have a proximal basilar and mid basilar, more often they are atherosclerotic in nature. Whereas the distal basilar is where the embolus goes and sits and really creates havoc, and that's exactly what happens in patients who have got a cardiac thrombus, especially in this low ejection fraction setting. When you have this situation, we will be lucky if it gets lysed away because it's a very fresh clot. In within quotes, it is easily lysable, and that's why sir said it was very appropriate to choose IV lysis. Call sir just taught us now, because it's going to be easily lysed being a fresh clot. However, if it doesn't open, it is going to have the worst prognosis because a major chunk is going to be involved. On the other hand, when you have a proximal or the mid-basilar, more often than not, they are atherosclerotic. And what it allows us is that because the occlusion carries on over a period of time, it allows us to form more collaterals. And therefore, it will not be as catastrophic as you will have a distal basilar. So we are always worried about distal basilar when it comes. These are the patients, ultimately, we brand them when they don't improve as a progressive basilar artery occlusion. And the prognosis becomes very bad for them. You're very lucky that with one IV shot, it really opened up. In fact, recanalization was shown by you. Both the PCAs opened up. And that's one of the reasons why the recanalization, in my opinion, was a reason why you got away with it. It's a really good case, really. You can also go and, if possible, if you have the images with you, you can analyze. There are two things which we can analyze there. One is that how good was the collaterals in this patient? If there has been a previous ischemia, collaterals would be there, and that would save the question. And there is a posterior circulation collateral score that has been developed. All you need to look at is sit with your radiologist and try to visualize the vessels and give some points. For instance, if you see the SCA, 1 point. If you see the ICA, 1 point. If you see the PICA, 1 point. And then look at the caliber of the posterior communicating artery. If it is the same size as normal site, then it is 2. If it is reduced, it is 1, not seen 0. So with this, you can calculate a rough score. And the persons who score well in this collateral score are the ones who really are lucky because they do very well after your lysis, be it mechanical or IV. In fact, the difficulty which we face is that most of the studies which we get across are for only anterior circulation. Whatever data you quoted, if you look at that, all of them, whether it is MR clean study or the SWIFT frame, whatever it is, the data is from actually the anterior circulation. The posterior circulation guidelines are not that dogmatic. However, it is believed that we should not have any difference of opinion. In fact, posterior circulation should be given more, gains for us because number one, if untreated, prognosis will be poor. And number two, we know that the ischemic window will be longer in a posterior circulation by nature. And that's the reason why we have a longer window. There are patients who have been thrombolized up to 79 hours. The initial papers talk about 3 days. And still they were taken for mechanical thrombectomy and they did well. So these are things which we should learn. Anyway, it's a good case and we are very, very lucky and showed the patient also with that progressive occlusion, still she did well. Congratulations, sir, and thank you very much for the lovely presentation.
Yeah, other question I had is that since she had 15% ejection fraction, what medicine she was on? Was she on double antiplatelets or single or oral anticoagulants? Do you have any information on that?
Yes, sir. So as I mentioned, she was only on single antiplatelet agent. That was ecosprin and statin, rosuvastatin. Sorry, atorvastatin, 20 mg.
Okay. Okay.
Sir, I have a comment regarding that, sir.
No, because this is this is a unresearched, although there are many trials, but the final word is not said that what should you do for these patients who are having low ejection fraction. As far as the current guidelines go, they say that if the patient the current guidelines say if the patient has not had a stroke, then you can give them just antiplatelets. But if they have now this patient, of course, she has atrial fibrillation also. I think this current stroke is not because of so much because of low EF, it is because of atrial fibrillation, because she has atrial fibrillation also. So but suppose if this patient had only EF low and no atrial fibrillation, then what is the best strategy for preventing? That is still not decided. They say for primary prevention, you should still give aspirin only. But if the patient has already suffered a stroke, for secondary prevention, then you can give them oral anti. But this is a different story because patient had a fibrillation which has been detected only during this stroke. Probably it was not detected before. And maybe it was there present before also. So that is why that makes it a little more interesting. But anyway, the outcome is very good. And that is what matters finally. Outcome.
Also, if there has been no atrial fibrillation, so I don't think he would have used a dabigatran or any of those NOACs, right, sir? In the routine low ejection fraction status, as of now, NOACs have not been, recommended. It's only the vitamin K antagonist if it is there. But if it is an atrial fibrillation, as you said, sir, I think they could use either one of them, either single or double, and no cardiologist would let them go without 2 antiplatelets.
Yeah.
Because all of them, even for a small ischemic myocardial infarction, even they always give dual antiplatelet and continuously as ever, sir. Like us, they do not revise it to a single antiplatelet. We have guidelines 6 weeks, sometimes 3 months, but as cardiologists, they just go on with the dual antiplatelet.
And many of the patients remain okay for years together, I mean, because our complication is because of the past stroke, because part of the brain is friable, so they are more prone to bleed. That's why we don't want to give it beyond 3 months.
So these patients, are they suitable for dual pathway inhibitor like rivaroxaban and aspirin, something like that?
That has not been studied in this subgroup of patients. That has been studied in COMPASS trial in patients with carotid artery stenosis. So we don't know.
So any comments from Dr. Anand Devanza, our second moderator?
Congratulations, Dr. Satyan. You managed it very well. Now it's very easy to discuss all those contraindications and how you ruled out one by one. But at that moment, it was really a brave decision with full of knowledge. You took it very well and you managed it very well, and you got a very good outcome. The only question I want to ask you is why a dose of 0.25 mg per kg was used instead of 0.2 mg per kg? Because with the recent trauma and the risk of GI bleed secondary to her ulcerative colitis, I am worried of her only problem or only complication of bleeding if I use a high dose. So I will consider 0.2, not 0.25. Otherwise, bridging and everything the same I will consider. So only the dose I am just want to know your rationale behind it.
Basically, what is approved in our setting in India is also 0.2 mg per kg. But as per the Western studies and the trials which are available, most of them have switched over to 0.25 mg per kg. Although, as I mentioned at the outset of my presentation also, if the patient was on hemodialysis and this was being used given heparin, I might have been contemplated to give 0.2 mg per kg, but as she had none of those risk factors and the ulcerative colitis was also in remission, I decided to go ahead with the full dose of 0.25 mg per kg.
And if she had an active bleeding, GI bleeding, then we would consider
then I would
only
not
mechanical, only mechanical directly, or?
Yes, sir. I would have definitely considered only for mechanical.
Without bridging and
no IVT.
Without IVT.
No, sir. No IVT.
Thank you. Congratulations once again.
Thank you, Dr. Anand, sir. Thank you, Dr. Satyan, sir, as well. Now, I would like to invite our second speaker, our second case presenter, Dr. Dubergerser, sir. Sir, would you like to share your screen, sir?
Yeah, I will share my screen. Good evening, everyone. Thank you very much for this opportunity. I am presenting this case in front of my DM examiner, that is Subhash Kaul, sir. I was in PGI. So good to see sir back again. Well, I gave a catchy headings just to catch attention, basically. Let us see how it goes away. My patient, a 60-year-old female, presented with 2-hour history of right-sided weakness and difficulty in speaking at around 10:30 p.m. She was hypertensive for last 2 years on treatment and had undergone routine health checkup 6 months back, which was normal. There was no history of any other significant illness in the past. On examination, pulse was 92 per minute. It was regular. There was no carotid bruit. Blood pressure was 160/100. Baseline IHSS was 10. So typical routine stroke within a window period. After taking consent and ruling out all the contraindication, she was considered for thrombolysis, and I usually, in those days, it is a little old case. Those days I used to do MRI and MRI angio, and then used to do thrombolysis. So MRI was done, which showed a left MCA superior division infarct. So patient was thrombolized. She recovered partially. NIHS is improved from 10 to 6 within first 2 hours. Post thrombolysis parameters, including blood pressure, blood sugar level, were monitored, and they were within normal limit. There was no increase in blood pressure. Sugars were less than 200. This patient was fine till 5 a.m. when I got a call from ICU in charge that patient has now left-sided weakness and she has deteriorated in her sensorium. So this was a real alarming situation. What happened is she had on presentation right-sided weakness, but now has deteriorated and has developed left-sided weakness with altered sensorium or drop in sensorium. So the patient's NIHS is increased to 20. She was immediately shifted for neuroimaging with possibilities which is always there in the mind. Post thrombolysis is whether she has developed any bleed, whether she has developed new infarct, or there is something else which is going on and I really don't know about it. So these were the thought. This was the thought process in my mind going on. With that, her MRI was done, and it showed now the infarct was on the right side. There was significant involvement of right MCA territory. That is why there was left-sided weakness, and she was drowsy because of that. Now she has developed. Now we start thinking what is happening basically. What she has developed infarct on another side. In fact, in previous case also the right hemipons was involved, and after post thrombolysis, the right hemipons, left hemipons was also involved, and there were the small cerebellar infarct also. So what is it? Is it cardioembolic? Whether patient has any dissection, whether patient has any coagulopathy, or something which I really don't know. So these were the thought process, because you have to think that what is happening in the patient, and another thing is you have to explain to the relatives also. So when in doubt, we review the old reports. Sometimes that gives us some hint towards what can be abnormal. The health checkup 6 months back, 2D echo, we just reviewed the 2D echo, and the left atrium size in 2D echo was mentioned as 46 millimeter. There was no clot. There was concentric LVH. So these are and LA size, LA dilated was mentioned only in the first page, not on the final report. So again, I missed it. The repeat echo we did, so considering that yes, this is likely to be a cardioembolic stroke, we repeated her echo, which showed there was a fragmented left atrial clot. During ICU stay, patient had paroxysmal AF, but her rhythm used to come back to normal. So patient really had a atrial cardiopathy with left atrial clot and fragmentation post thrombolysis leading to infarct on other sides. So this was the reason why patient deteriorated post thrombolysis. So the future course, what happened to this patient? The patient had deterioration in NIHSS. She required right hemicraniectomy. She was shifted to higher center because she was one of the politicians in our place. She had a huge contact, but she recovered after shifting to Mumbai for rehabilitation. She had a partial ambulation on follow-up. She did relatively well. Her NIHSS when I saw last was around 6, and her MRS was 2. She was ambulatory with support. So what does the literature say about this left atriopathy? That cryptogenic strokes, where we don't know the etiology, they account for almost 1/3 of the stroke patient. And recently, this condition, atrial cardiopathy, has been portrayed as one of the mechanisms for the stroke. And there are certain serum biomarkers, there are certain imaging, and there are certain electrocardiogram biomarkers that have been shown to be associated with ischemic stroke. And this is irrespective of whether patient has AF or not. They may not have AF. This is what is very important, that we should not think only of atrial fibrillation. As the discussion happened, yeah, atrial fibrillation is only one of the markers of this atrial cardiopathy. It is one of the events which happens with atrial cardiopathy. It is not the sole reason why people develop cardioembolic stroke. I will discuss that. So this is the virtuous triad. We all know that there is, in this condition, in left atrial cardiopathy, all these 3 things are happening. There is a stasis because of left atrial enlargement. There is endothelial dysfunction. There is increased coagulability. Then what happens to the left atrium? Basically, there is myocardial fibrosis, there is impaired myocyte function, chamber dilatation and inflammation, and then there is a left atrial appendage characteristics. There is left atrial appendage morphology. There are 4 classical morphologies which are there in left atrium. There are the 2 most which are commonly associated with this is cauliflower and cactus. Windstock has got less chances, and then the chicken wing, which is the morphology of left atrium, which is seen on the transesophageal echocardiography, has got the least propensity to produce the stroke risk. So the 2 most common are cauliflower and cactus morphology. These are on T, where if we see that, then these patients are at high risk of developing cardioembolic stroke. Then increase in size of left atrium. Then there are number of lobes. Normally there are 2 lobes. There are certain people who have 3 lobes, 4 lobes. Some people have 1 lobe. So that also plays important role. And then because of all these things, there is reduced emptying. There is flow velocity changes which are happening in the left atrium. So all the 3 factors of virtuous triad are there. So what happens, why these patients are prone for stroke is that these patients who have systemic insults, say diabetes, hypertension, obstructive sleep apnea, obesity, aging, autonomic nervous system dysfunction, they develop structural atrial alteration like degeneration, apoptosis of myocyte, fibroblast proliferation, endothelial remodeling, and atrial fibrosis. So the result is what? It leads to left atrial dilatation. So atrial stiffness and impaired electric conduction, which leads to abnormalities like premature atrial complexes are also there, even PSVT, and then patient will develop atrial fibrillation. Along with that, there is a left atrial dysfunction, reduced atrial pump function, impaired reservoir function, which all leads to atrial blood stasis, atrial prothrombotic state, and then finally it leads to ischemic stroke. So there are certain, as I said, there are certain biomarkers. So in the serum, we should do serum pro-BNP levels. If they are significantly elevated, say more than 1000, then it is indicative. I'm saying in a patient who has suspected left atrial cardiopathy, not in a patient who is already in failure, but these serum pro-BNP levels, if they are significantly elevated, then it is a indicator. Then we have echocardiographic criteria, and then there are ECG criteria. In the ECG criteria, there are many criteria, like say increased P wave dispersion, increased P wave duration, increased PR interval, increased P wave area, and the most important one which is used in the for the biomarker is increased P wave terminal force in V1. Now, what is that P wave terminal force? Is the value of the amplitude of P wave multiplied by the duration of the terminal negative portion of the P wave in lead V1. So that is, if it is significantly increased, then it is indicator of atrial cardiopathy. Abnormal P wave axis, and as I said, premature atrial complexes. So these are all markers of the atrial cardiopathy. And the third criteria is 2D echocardiography. In the 2D echocardiography, there are 3 or 4 criteria which are important. One is, as I said, the left atrial size itself. Usually what guidelines say, if left atrium is more than 40 millimeter in females and 42 in males, that is a cutoff basically. Beyond that, it is called as left atrial enlargement. Few people, to be more precise, they take left atrial size compared to the patient's BMI also. Then there is spontaneous echo contrast or SEC, which is seen on the left atrium. That is another marker. And as I said, left atrium morphology, whether it is cactus shape or cauliflower shape, which are again, and how many lobes are there. And left atrium volume is another criteria which is used. So why this atrial cardiopathy develops is that there are many studies which shows that there is autonomic dysfunction. What is it? Sympathovagal imbalance leads to inflammatory cytokines, renin-angiotensin system activation, oxidative stress, and fibrosis of the myocytes. It all leads to the inflammatory cascade, producing structural atrial alteration, atrial cardiopathy, and leading to cryptogenic stroke. So to conclude, atrial cardiopathy may constitute one of the mechanisms in stroke, especially cryptogenic stroke. Then there are studies are needed to determine the degree of overlap between these atrial cardiopathy biomarkers and which one is more useful. I told 3-4 criteria. Which is the most important one? We still don't know. There are very less studies about this condition. Then patients with evidence of atrial cardiopathy constitute a group of patients in whom clinical trials are warranted. As Kolsar said, that whether anticoagulation, we all know that as Sir said, atrial fibrillation, we are never unsure that yes, these patients require anticoagulation. But even the patients who have got left atriopathy, I think they are candidates for anticoagulation, because atrial fibrillation will result in them in the end, because it's again, atrial fibrillation is one of the biomarkers of the atrial cardiopathy. Now to discuss few things, which is why we are here, that when should we do 2D echo in a patients who are for thrombolysis? Suppose if we do 2D echo, if it is available in emergency, I know that we should not wait for this investigation. And if we find a LA clot, what should we do? Whether we thrombolize those patients or we don't thrombolize? And if we find a left atrial enlargement in a patient who is on your routine follow-up and you do 2D echo, what are you going to do with that patient? What kind of treatment you are going to start? And there is no past history of stroke in that patient. So what we are going to do that? I think this was all from my side about presentation. I think we can discuss all these points with the help of Meenakshi Sundar sir, Kaul sir, and Dr. Devanza sir. Yeah. Thank you.
Dr. Kaul sir.
Dhananjay, that was once again you showed a very interesting observation, and all of us have once in a while had patients whom we thrombolize and suddenly he worsens. And this is a known phenomena which can happen in two situations. One is when there is a existing clot in the heart and it gets fragmented by our TPA. Job of TPA or job of thrombolysis is to fragment the clot only, but it depends on where does it clot, what is the location of the fragmentation. So the thrombolysis is working well, but it's working at a wrong place. So we have seen it. And second times, what I have also seen is that even when there is a proximal thrombus in the proximal artery, you know, for instance, in the carotid artery, and you give it, that can also sometimes fragment and patient has worsened. So once in a while, we have seen these patients. And as of now, we have not developed any mechanism based on guidelines or consensus that what should we do. We just are silent spectators, but you have raised very important points. So my personal opinion is that if we can do a quick 2D echo in the stroke unit or emergency department, that would be a very good thing. It is not in guidelines, that's why it's not being done. In guidelines, they don't require it to be done. So that's why it's not. If it was in guidelines, it would definitely be done. But I think if it does not waste time, and I think how much time does it take to do 2D echo? 5 minutes? If there is a trained person there and you have to just put that thing there, the probe, and have a look at that. Definitely in the recent myocardial infarction would be one group where one should do it in the recent, because you would be looking at the pericardial effusion, you would be looking at the echinacea, because a echinacea, big echinetic segment following post myocardial infarction, they are at risk of clot. You will look at the clot also. They are at risk of cardiac rupture also. You know, on the second or third day of MI, if a patient gets a stroke, there's a good possibility that he has a clot, and even if there's not a clot, there's a echinetic segment there. And that is why MI used to be a contraindication for thrombolysis many years ago. Now it's not a contraindication. But so that would be one group. But I think cases like this, which you have shown, they may not have a history of MI also. And there may be 2 patients out of 100 like this. So I completely agree with you. And I don't know whether we can, because till it comes from USA, it cannot come from us. But I think it is a good idea to just immediately, as a screening, to have it depends on how much time the echo will take. You know, if we have to send a call to a technician and the technician has to ask a cardiologist, by that time that echo machine comes and then it takes another half an hour, then it is absolutely self-defeating. Then you cannot do it. But if we have such a mechanism in our center where you can do a 5 minutes or 10 minutes echo, by the time you will do other investigation, that will be an excellent idea. Now, your second question was that if you find a LV clot or LA clot, should you still thrombolyze? No. I think if you have got a mechanical thrombectomy, I would definitely do. This would be one of my choices for direct mechanical thrombectomy. But if direct mechanical thrombectomy is not available, then I would do it. I mean, the chance of that left atrial clot fragmenting, it will not fragment in everybody, but it will fragment in 2 or 3 patients out of 100. So I would take a high risk consent and do it. But if I have a facility of mechanical, which I have in my hospital or many hospitals have, this would be a justification of going directly for mechanical because there's the risk of fragmentation. And your third question is $1 million question. This Dr. Ranjan from Apollo Delhi keeps on giving a lecture on cardiopathy every time. This is his favorite topic. That if you find that there's a left atrial cardiopathy, should you put them on anticoagulants or not? And I think as of now, it has not come in guidelines to the best of my knowledge. It has not come in guidelines, but I think even if you put it, you are not wrong. If you explain to patient, and some cardiologists have started doing it, that you have to explain to him that, look, your atrial enlargement is there. There are studies which have shown that you are at a high risk of, therefore I am putting you on oral anticoagulant. But you must know it is not in guidelines unless it has already come. I have not checked yesterday or day before yesterday. I have a feeling that something in cardiology guidelines, probably it has come. That is my impression. What do you say, Dhananjay? Have you checked that?
No, sir, I have not checked, but in our stroke guidelines, definitely it is not there, sir.
No, it's not there. It's not in stroke guidelines.
I have not checked about cardiology. We'll just check, sir. I have not checked. Yes. Sir.
Yeah. Great case. Meenakshi, your expert comments.
Sir, regarding the echocardiogram in the emergency, sir, we do have an handheld echo, sir. That can be very well done in the emergency, sir.
How much time it will take, Meenakshi, according to you?
It will take 2 minutes, sir. Because
fantastic.
Only one thing the resident has to see, sir. We trained one of our residents to just say whether there is a clot or not. But nowadays we are not doing it, and I will tell you why, sir. We started that practice because of a single purpose, sir. We got hold of a handheld echo, by which time we also had a patient who did develop a complication similar to Dr. Dhananjay sir's case. Our case did not have actually a stroke, but he developed myocardial infarction. And I think that was one of those times when in Neurology India also there was a paper published from India only about a similar case. And we were, it was a very difficult thing which we went through, having to explain a person about myocardial infarction after thrombolysis when they knew that thrombolysis treats myocardial infarction. So to sit and explain to that patient was really nightmarish, and we had a tough time telling them all those things. At that time, one of our residents, Dr. Sabari, who was a resident in our emergency those days, he is the one who got trained. Dr. Sabari would just see and tell whether there is a clot or not. That is all.
Yeah.
Only 1 minute will take. It's one machine. That's all.
That's great.
But then we had a difficulty, sir. Then the question that was asked in our discussion was as follows. We also decided that if there is a clot, we'll go for mechanical. But if the person does not have a major vessel occlusion, has come with thrombosis now, whether we are going to lyse or not was a question raised, sir. And we did not have an answer. We try to seek answers for that, sir. You have to teach us before we leave whether you will lyse that patient who does not have a major vessel occlusion. At the same time, he has also got a clot. Will we lyse it? Because we had a very bad experience. One, I can tell you, sir. This was the first comment. I'll give the other comments after you have taught us this point.
No, Meenakshi, you see, the whole practice of medicine is a practice of probabilities. So the question is of probability of lysing the clot in brain or achieving some good outcome in the brain versus the chance of fragmentation of the clot in the. So I think I would have to give him that option because we have to go along with the existing guidelines also. So as per the guidelines, there is no mention of these clot in the heart and all. We know from our observation and from the mechanisms that this is a risk, but it is not a contraindication. So therefore, I will tell the patient that, look, you see, when we give them, when we thrombolyze, no, in any case, we discuss with the family, it is a shared decision making. If you see the guidelines of American Stroke Association these days or anything, on the first paragraph, he says shared decision making. So I'll tell the brother of the patient or the wife of the patient, look, I'm thrombolizing him for dissolving the clot in the brain, but there is a chance he may. If she says, no, I don't want to take that risk, then I would not do it. But you can't deny him thrombolysis because as per guidelines, it's nowhere a contraindication. That's what I would do.
So this is the reason why we are not anymore doing it, sir. We're not very enthused about it because it did not change our thinking. But as you said, sir, we'll again go back and do it. Now our present residents...
You know, Meenakshi, on a lighter vein, you are so right because sometimes ignorance is bliss. Because sometimes we get information which stops us from taking action. We don't need that information. And I know some stroke neurologists, they do only CT scan, they don't do MRI. I said, why don't you do MRI? He said, then I'll be caught in that problem of flare change and this change and diffusion change and SWI change. I just do CT scan. If it is normal, I go ahead and thrombolyze. So you're right. Sometimes extra knowledge also creates impediments for us. So it is good. That is on the positive side of not knowing things. Yeah.
The same things in our hospital also, less than 3 hours, only CT, sir. I told them, don't do MRI. It will only confuse. No, nothing is in the CT, go ahead. Only if it is beyond 4.5 hours, or like the first case which was presented here, where the stroke itself is doubtful, or we think that the deficits are too minimum, will we really thrombolyze? Or we have an associated issue, there was a history of trauma which will do anything for us. Only when these issues arise, we go for MRI, sir. Otherwise, only CT we are doing in the initial one. So this is one thing. The second thing is a very interesting concept about this atrial cardiopathy, which Dr. Dhananjay brought up, sir. I was also very excited about it. The reason is because it has been one of the most hard discussed events. The reason being is as follows. Now, when you look at that, what defines stroke in patients who have got an atrial fibrillation? So the guidelines say that you who will develop stroke is that if they have at least 6 minutes of AF, that was a study which was shown that if you have 6 minutes of paroxysmal AF, it is as good to produce stroke as you have got a persistent AF. 6 minutes was a guideline. Now the intuitive question we'll get is that how can just a 6-minute run of AF be strong enough to produce a thrombus? It doesn't sound logical to us. How is it possible that 6 minutes also produces that? The second thing which came was on the patients who had put on a pacemaker and they were studied. And it was seen that a good number of patients developed stroke, and at that time there was not much atrial fibrillation. There was only supraventricular tachycardia of other nature, not amounting to atrial fibrillation. That was the second thing that was shown. And there are good number of patients who have had ECGs done before, who had stroke and AF together. In other words, both of the events happened together. So we may not be able to really implicate atrial fibrillation as the etiology for the stroke. So that explains what is this atrial cardiopathy, which Dr. Dhananjay talked about, the P-terminal force. In fact, atrial cardiopathy gives a substrate for thrombus. There is a thrombogenic atrial substrate. Now, this atrial cardiopathy predisposes to the formation of thrombus. It also predisposes to the formation of atrial fibrillation. It is not that it predisposes to the AF and AF leads to stroke. It is independently produces both AF as well as thrombosis. If we understand this concept, then we will understand that atrial cardiomyopathy by itself is a risk factor for development of AF. And that is the reason why studies have been done to look at only this atrial cardiogenic substrate and whether any of these anticoagulants would be of benefit to that. Unfortunately, all the newer anticoagulants which have been tried in this subset have failed. So we, as of now, we do not know the answer whether we can anticoagulate them and still get a benefit just by diagnosing an atrial cardiopathy. But there should be good reason and good knowledge that should emerge in the future. I think that was a very good case for discussion for all of us, I think. Exciting thing about atrial cardiomyopathy.
Dr. Anand?
Excellent case, Dhananjay. A lot of discussion on it. Again, just again a query. If you want to anticoagulate such patients of atrial cardiopathy, again, vitamin K antagonists or no wax to be used? So this is like if it's a substrate for thrombus, at the same time substrate for the AF to generate, like a non-valvular AF.
Yes, as sir said, there are the newer oral anticoagulants have not been proven till date. Yeah, so exactly when something is not proven, we rely on whatever is available, conventional vitamin K antagonist. Yeah, exactly. Warfarin acetone should be used. If in future, if the trial proves that newer oral anticoagulants are useful, then we may shift to newer oral anticoagulants in that situation.
Yeah.
Sir, I am interested in knowing how he explained to the patient that he came with one stroke and the patients are going to say, you gave another stroke to us. What did you tell them, Dr. Dhananjay, sir?
Yeah, I really had a tough time, sir. And most importantly, they were politicians. So you can imagine my anxiety and agony. Only thing, I got relieved when they got transferred to Mumbai. That's the only time when I felt relieved. Otherwise, I kept on saying that this is known, this is happens. You can take. Actually, what I did, Hastak sir was there in Mumbai. I had taken their consultation. Before they moved to Mumbai, I asked them to take his opinion. So they went and showed all the reports, and then they were relatively satisfied that yes, this can happen. Basically, yeah, they accepted finally that this can happen. So they moved on basically with that.
See, all these events, no, these are events. These events can happen. And as doctors, no, we somehow own the events and we feel guilty and we feel responsible as if we have caused them. No, this patient met you when she was 82 years old. Before that, you never knew her. So you have no control on the patient's life, on her risk factors, but you meet her at a point and suddenly you feel that you are responsible for that. So I think we have to decondition ourselves from that thought. Only thing, we have to make sure that we are not committing any mistake. That is the most important thing. But after that, as far as the outcome is concerned, that really is not in our hands. We only do our best. And that is the whole concept of shared decision making. We don't know which decision is correct. Nobody knows. I mean, if you see the guidelines, what is class 1 recommendation, class 2 recommendation, class 3? Please read it carefully. It says benefit is more than harm, but there's harm nevertheless. Even in class 1 recommendation, there is harm, HARM, but benefit is more than that, right? That means 30 patients will be harmed, 60 patients will be benefited. This is the concept of class 1. Then you come class 2, then you come class 3. Then in class 3B, harm is more than benefit. That's where it comes in red. So what we have to know is that, but only thing is that we should not miss anything. If we miss, then that is negligence. But in the natural course, if something happens, natural course of disease, we can't help it. That is why the medicines, that is why after going through these experiences, we are discussing that we should probably do 2D echo. But in today, if you have not done 2D echo, you will not be blamed because it's not supposed to be done. But maybe after 1 year, that will become part of the guidelines that you must do a 2D echo. Like we have to do a CT scan. But as of today, 2D echo is not supposed to be done because it wastes time. I'll tell you, if there are 5 minutes, I'll tell you similar. When I was introduced to this atrial cardiopathy for the first time was about 6 years ago, when my father-in-law, my own father-in-law, personal story, he underwent a pacemaker and he went for a routine pacemaker check. Pacemaker is already implanted and he went for a routine pacemaker check. And the cardiologist who saw, he called me aside. He said, Dr. Kaul, your father-in-law is having a atrial cardiopathy. I said, but pacemaker has been put. Why should we worry? He said, no, pacemaker will do nothing to the atrial cardiopathy. Pacemaker is for a conduction defect, AV block. He has a cardiopathy, he has a very supraventricular tachycardia, paroxysmals of supraventricular tachycardia, and they are as bad as atrial fibrillation. And this is a forerunner of atrial fibrillation. He should be on anticoagulants. And at that time, he didn't even have AF, but he had supraventricular. He said he should be on anticoagulation, and he was a friend of mine, so he stuck his neck out, and he said you should, but do one thing, get his endoscopy done, because he's 85 years old. I don't want to put him on anticoagulants before checking he doesn't have an ulcer. I told him that, but we don't routinely do endoscopy. He said, we don't do routinely, but better to do it, you never know. We got his endoscopy done, and to my horror, the gastroenterologist phoned me in the afternoon that he has got a gastric carcinoma. And this is about 5 years ago. Now the anticoagulant go into the background. Now the whole attention goes to gastric carcinoma. So now we are doing ultrasound, and the cardiologist said, okay, I can wait. Don't worry about this thing. This is more of an emergency for this gastric carcinoma. Now, ultrasound and all, PET and all was done. It showed it was still limited to his stomach only. It had not gone to lymph nodes and all. So we went to the best gastro surgeon in our city, and he was operated 5 years ago. And 5 years down the line, he's perfectly all right, and he is not on any anticoagulants. he's only on ecosprin, and he continues to have those runs of atrial tachycardias. So then I thought that I should get it reviewed done. So I went to the cardiologist. This time it was a different cardiologist because my hospital had changed, right? So I went to the electrophysiologist cardiologist, and he also did an electrographic study of his heart. And he says, Dr. Kaul, I'm I'm horrified to see his cardiac status. I says, what? He says, not only has he supraventricular tachycardias, he has runs of AF also. And he must be on oral anticoagulants. And he said, apixaban is a good choice. And because of his age, I would put him on 2.5 milligram BD. I said, okay. So we put him on 2.5 milligram BD. For 1 month, he was all right. After 1 month, he started having torrential bleeding from his urine. Torrential bleeding from urine. So now he is not on any oral anticoagulant. It has been decided that he cannot tolerate anticoagulant. Forget about it. Now he's on good old aspirin. So the point which I want to make is that each patient and each patient's situation and the circumstances surrounding keeps on constantly changing. There's no one thing written in stone. This is my personal experience about atrial cardiomyopathy, but then my father-in-law has been having it for the last six years. And every time a phone comes from his home, I think he has got a stroke. But till now, he has not got. And I have told my wife, someday your father will get a stroke. But there was one relief, because we always feel guilty when a patient has a stroke. As long as he was on apixaban, I thought even if he gets a stroke, I will not have to thrombolize him at least. Because that's a contraindication if he has taken his apixaban in time. But now that he's off apixaban, I'll still have to thrombolize him. So it's increased my work. Over to you.
Atrial cardiography is a risk factor for gastric carcinoma.
Is it? No, it's case report. Yeah.
It's a forerunner.
Yeah.
Thank you, sir. I believe we are at the far end of the meeting, and I would formally like to give the vote of thanks. And we have exceeded by 15 minutes as per our daily schedule, but I believe the discussion went in so much, and the case, Dr. Kaul's personal experience, that again was change and elaborative in terms of decision making and shared decision making. I would like to thank our case presenters today, Dr. Satyan Nanda and Dr. Dubergerser, for their excellent cases today. And our moderators, Dr. Sundaram sir, as well as Dr. Anand sir, for their expert comments, and our course director, sir, Dr. Kaul, for your course direction, at the same time, the entire governing and guidance that you have provided us all throughout. So, I mean, I believe this was an exciting session, a lot of things to learn, a lot of things to exchange. We had a total of 168 logins today who were attending us on a continuous basis. We were monitoring them. And I believe everyone would have had a good take-home message, which they would have recorded for them, and that would help in better patient outcomes. So I thank each and everyone today present in the meeting for their excellent deliberation. Thank you all. Thank you.
Thank you.
Thank you very much, sir.
Thank you. Namaste, sir.